cannulate them. Medial perforations can be potentially catastrophic. Then you have the angulation of the pedicle itself. That itself is variable, and likewise for the facet joints and the transverse process, this anatomy is variable across segments. Indications are many, which we are aware of. Now, I am going to present basically about the freehand technique used. The others are fluoroscopy guided, navigation guided, laminotomy. So what are the main considerations when you insert thoracic pedicle screws? So it's about pedicle size, the transverse angle of the pedicles, which are very variable. It is important to identify the landmarks, especially the transverse process and the superior articular facet, and the starting point, which is also variable. Now, starting with the pedicle diameters and the shape. So the shape, as you can see here, it's kind of oval shaped, and the craniocaudal diameter is, you can see, is longer than the mediolateral diameter. You have pretty much large pedicles at T10 to T12, and then it progressively reduces, and then from T3 to T1 again it increases in size. As you can see here, multiple studies have confirmed the same thing. These are all anatomical studies which have been done. Some Indian studies are on this side, and you can see here the lower pedicles accommodate large screws, and likewise the cranial pedicles. But between T4 and T6, they are sometimes very, very small as 3 millimeters or 4 millimeters in some Indian studies. So one useful study was done in MS Ramaiah in 2010. Dr. Pai and his group published it, and we can see estimate the diameter and the length of standard screws to be used in Indian patients. So the lengthwise T1 to T2 can put about 25 millimeter screws, and T3 to T5 about 30 millimeters. That is the length we are talking about, and at T10, 12, 40 millimeters. Sometimes accommodates up to 45 millimeter, but 40 mm is quite safe. Now this rectangle, it basically tells us D4 to D6 diameters. Some of these diameters were very small. So this was a CT and a cadaver study. So some of these screws are 3 to 4 millimeters. So it may not accommodate the standard, the smallest 4.5 mm thoracolumbar instrumentation. So when you put a 4.5 millimeter screw in such cases, you can use a in-out-in technique. That is where you go into the bone, and then you go just lateral to the pedicle. At this point, it might actually come out of the pedicle, but then you have the rib head there. So you stay medial to the rib head, and then angulate it quite medially so that you are inside so you are in again. So the in-out-in technique. So that is inside the body. So the other thing is the transverse angle. So this is also variable across the segments. So it's quite wide angle, like much more lateralization is required, or rather medialization is required at T1 and T2. So it's about 25 to 30 degrees there, and it reduces quite sharply when you come to about T4, and it's almost parallel at T12. These are multiple studies which have confirmed the same thing. So you can see that it's consistently 25 to 30 degrees at T1 and T2. Now, and at lower levels, it can be quite parallel, or is sometimes even slightly divergent. So at T12, that means you have to have a bit more of if you start a little more laterally and have a more converging angle at T12. This is another graph which tells you another study where you can see the drop off from T1 to, and then it's about 15 degrees or so, and then many other studies have shown it's quite parallel. So the next thing would be to identify important landmarks. So one is the transverse process and the other one is the superior articular facet. Now here you can see the superior articular facet and the the transverse process here. So it's very important to identify the superior ridge that gives you a beautiful landmark and the lateral border of the superior articular facet. Now these 2 points will actually guide us to the starting point. So it is important to identify this properly, to do a inferior articular facet IAP osteotomy. So you remove that part of the bone, then you can easily identify the superior articular facet, and at the lateral border, at the lateral 1/3. So the Lenke's chart, basically, Lenke is one of the very famous deformity surgeons in the world. So he has given, which he has done like more than 10,000 screws. Based on that study, they have identified the start point as the, so you divide the SAP into 3, the medial 1/3, mid, and the lateral 1/3. So the junction of the mid 1/3 and the lateral 1/3, draw a line down and take a point, draw the superior ridge of the TP, and at that point, that is the start point which is described. Now this is the ideal start point for mid thoracic screws and up to T7 to T9. So this is the right start point. But going cranially and caudally, so the start point will be a little more caudal to this and little more lateral. So here. So for T1, T2, you take a start point which is mid TP and lateral border of IAP, lateral border of superior articular process. So that holds for T12 also. So based on this, this Lenke's chart is very popular. The Medtronic people actually, they give this chart. They have this poster put up. So you can see the different start points for this. So another important thing is whether how much you can converge, how much. So whether you go straight. Now this depends upon the start point in the mediolateral plane. So if you take some authors describe midpoint of the SAP as the correct spot to start. So if you take a little more medial point, then you can only go straight. But if you go to the lateral 1/3 or even lateral to that, you can converge more. So as you know, convergent screws are biomechanically more stronger. They have a greater pull-out strength. So other thing is the trajectory in the sagittal plane. So you have a anatomical and a straightforward trajectory. So in the anatomical trajectory, this follows the natural direction of the pedicle, and you can put longer screws. But if you use a straightforward trajectory, that actually goes along the parallel to the end plate, and going parallel, you have more cortical bone purchase going parallel to the end plate. This goes into the cancellous bone, the anatomical trajectory. So this straightforward trajectory increases the pull-out strength by 40%. So a rule of thumb, if you want to put a straightforward trajectory, is actually to go assess the vertebral inclination based on the amount of kyphosis, and then place it perpendicular to the body, like you see here. So when you have like so many different start points, you can get a bit confusing. So in 2014, Fennell and their group, they published an article which gave a very simplified version of the start point and the axial trajectory. Now, for all T1 to T12, you take a point 3 millimeter below this notch. That this notch is the junction of the transverse process and the superior articular process. So you take 3 millimeter below that. That is a start point for all the levels. And then the axial trajectory is 30 degrees medialization at T1 and T2, and all the levels below that it's 20 degrees. Now, this can be used with a bit of a caution, because sometimes at lower levels this much angulation can be a problem in some patients. Now, the accuracy of this technique actually was studied by a CT-based simulation technique by Dr. Vivek Joseph and his team here. 240 screws they had simulated, and they have checked the ideal angle versus the Fresnel angle. So we can see this is the ideal angle, and there was not much difference for the first T1 to T10. So you can use that very comfortably. So it is quite accurate. But at T11 and T12 we can see a medial breach. So they suggest that you should not use such a medial angulation, so you can use less than 10 degrees angulation, or you can actually go slightly more lateral to put these screws. So you should do in a systematic manner. So first you rongeur the medial aspect of the TP. This you create space for the tulip, and then you create the start point. So by using the landmarks which we described earlier, the anatomical start point, and then you can make it using a awl or I prefer a 3 millimeter burr. So you see a pedicle blush actually, and you can actually see the start point. Then use a Lengay probe. So this Lengay probe is designed, you might have all seen it, and it has got a slight curve. So use that curve facing laterally initially, and go about 15 to 20 millimeters. So that means you've crossed the chord, and then take it out and then turn it and put it medially. So then you can go till the end, and then you under tap by 1 millimeter and then put the correct screw. So so that's about pedicle screws. So now we come to hooks. It's not generally very much widely used, and my experience is also limited. I have a disclaimer, I have not used laminar hooks, but I have used pedicle hooks and TP hooks. So these hooks are basically adjuvant fixation devices to augment pedicle screw fixations, and sometimes when you have difficult anatomy, very small pedicles, you can use these adjuvant fixations. So in general it comprises of three parts. One is the tulip, that is the head, then there is the throat and the shoe. So this throat width is basically, it should match the thickness of the bone. So if you are putting a laminar hook, it should not be having a too wide throat height, otherwise it will go and compromise the spinal canal. And also with regard to shoe width, it is easier to place a smaller shoe. It's much more easier to place this one, but a wider shoe actually gives more bony purchase and less flow through. So this is a pedicle hook. Now pedicle hooks are easy to identify. It shows a bifurcated pattern here, and this is basically designed to go under the inferior articular facet. So it goes underneath the IAP and seats against the pedicle superiorly. So to place this, you have to have a pedicle seeker and a pedicle hook applicator. So you can see for the pedicle hook applicator, this two handles. One is the accessory handle. This is the handle on which you mallet. So this is the handle on which you place the pedicle hook. So you definitely will have to do an osteotomy for this, a little larger osteotomy than described earlier, and you use an osteotome. This care should be taken to direct it away from the cord, otherwise you can plunge, and using a drill sometimes is more controlled. So use a pedicle seeker. Basically initially it's placed, it is malleted a bit obliquely, So it goes under the inferior articular facet, and then you bring the handle down, and it goes horizontally to seat against the pedicle above. So, like I said earlier, this tapping is done on the accessory handle, and you tap it in onto this, and while this is a pedicle hook applicator, so it has to go and sit against the pedicle. It is best used to distract the upper instrumented vertebra or the concavity of the deformity. Second is the transverse process hooks. See where the transverse process hooks sits in. So it sits between the head of the rib and onto the transverse process. So it's mainly used in the upper instrumented vertebra to correct coronal imbalance, and where pedicles cannot be used. Used in the upper thoracic levels, because the lower levels these TPs are smaller and more vertically oriented, so you cannot use these TP hooks. So it's applied in this manner. Usually you start lateral to the facet joint, and it is started in with the hook, the seeker angled medially, and then you slowly rotate it laterally and go underneath between the TP and the rib head anteriorly. So, and then you can gently pull the TP up, bring the handle more vertical. So once you have created that, you can just put the TP hook there. Second is the laminar. The third one is the laminar hooks. Now, this is basically used to protect the pedicle hooks at the upper instrumented or the lower instrumented vertebra. And because these are more medial and may not align with the rest of the pedicle screws, you can use offset hooks. They will align with the adjacent pedicle screws. So there are two types. One is the supralaminar hooks and one is the infralaminar hooks. So these supralaminar hooks are downgoing and used at the upper edge of the lamina. You can see the upper edge of the lamina is more cortical and it is thinner. But these are very strong, and this supralaminar hooks also, so you can see that the throat height is smaller to accommodate this, and then also it is a little obliquely placed, that is to accommodate the slope of the lamina, right? And then the infralaminar hooks you can see here, they are got a much more wider throat, and it accommodates the wider caudal edge of the lamina. So these are infralaminar hooks. You have infralaminar hook seeker, basically which seeks the space between the bone and the ligamentum flavum there. So it starts medially and then you create that space there. So always stay on the bone so that you don't plunge inside, and you dissect the ligamentum flavum of the bony part. Then once the that is done, you can place the offset infralaminar hook. The supralaminar hooks actually are much more difficult to place because the space available, especially in the upper thoracic spine, you know, they are all crowded together, and you have to use a distractor, laminar distractor for these. But these supralaminar hooks are very strong. So you start with the pedicle, the lamina spreader, and use this lamina seeker to dissect the flavum of the upper edge of the lamina. Start by it facing the 90 degrees medially, and then slowly rotate it against the ventral edge of the ventral part of the bone, and usually you use a short throat supralaminar hooks as described earlier, and then it has to have a thin foot plate also. This is the final position of the supralaminar hooks. So in conclusion, there is a wide variation in thoracic vertebral anatomy across the segments, and in especially placing pedicle screws. These variations such as pedicle size, transverse angle and the start points will have to be clearly understood to prevent complications. Pedicle hooks or the different types of hooks can augment the fixations, especially in deformity surgeries. Thank you.
Thank you, sir. Thank you for your talk. Any questions for Dr. Jacob? May now request Dr. Vivek to give a small token of appreciation to Dr. Jacob. May now request Dr. Bijesh to tell us about lumbar spine anatomy, lumbar decompression, lumbar pedicle screws, sacral and alar wings with sacrectomy.
The center button. The video is playing. Yeah, Sudarshan? I keep changing with this, right? Yes. Okay, fine. Good morning, everyone. We have finished cervical and thoracic, and let's go to lumbar and sacral anatomy. And here I'll be talking more about the principles of placing a lumbar pedicle screw, lumbar decompression, and principles of sacrectomy. So we have seen the basic anatomy of the spine, vertebral body, and all. Let me tell you how is it different. Lumbar vertebral bodies are larger compared to cervical and thoracic. They got larger pedicles, oriented medially, and you look at the facet joints. This is the superior articular facet. You see that it is more obliquely placed compared to a thoracic spine, where it is more anteroposteriorly oriented. And if you want to place a pedicle screw safely, you can see that this is the joint line, and the screw should be lateral, should be placed lateral to the superior articular facet and then directed medially. So the important landmark here is the superior articular facet, to identify the superior articular facet and stay lateral to the superior articular facet for a safe placement of lumbar pedicle screw. And you look at this sagittal recon, you can see this is the neural foramen, which is bounded anteriorly by the vertebral bodies and the disc. Posteriorly, you have the facet joints. Why is this important? Because the nerve coming out, the nerve root coming out, it stays in the upper 1/3 of the neural foramen, and any pathology that narrows this space will cause compression of the root, especially any lateral disc or any hypertrophy of the superior articular process. You can visualize something. This is the superior articular facet. If it hypertrophies, it will encroach into this space and compress the nerve root coming out of this space. And next thing is to look at the orientation of the pedicle in relation to the TP. You can see that the TP and pedicle are almost in the same line, especially at L3 and L4. And if you look at because of the lumbar lordosis, you can see that it is slightly cranially oriented in the upper vertebrae and slightly caudally oriented in the lower vertebrae. So I've talked about two structures in relation to the pedicle screw placement, or one is superior articular facet and other one is the TP. So if you look at the axial view, and this is the view what we are going to see when we are exposing the spine for a pedicle screw placement. You can see that this is the superior articular facet, this is the inferior articular facet, and this is a pars interarticularis, and this is your TP. So you start exposing from the spinous process, expose the lamina, the pars, and expose the superior articular facet. Expose the TP fully. You have to expose the superior surface, superior edge, and the inferior edge of the TP for a proper identification of the entry point. So as we have already noticed, the entry point is going to be lateral to the facet joint, and it is in relation to the TP. So you know the indications. Basically, it is an unstable spine for any reasons, and contraindication being any active infections, or in a situation where you don't you don't have to, you don't destabilize the spine while doing a decompression. The fixation is not needed. So you look at the entry point, the starting point of the pedicle screw. There are different techniques mentioned, but what we have to realize again is the joint line. There won't be any entry point medial. It will always be lateral. And if you see, this is in line with the facet joint. This is in line with the superior articular process, bisecting the superior articular process, and this is more laterally placed one. So based on the entry point you choose, if you're choosing an entry point which is more lateral at the valley or the nape of the transverse process, your pedicle screw has to be directed more medially. You can't have a screw going more straight here. Similarly, if you are doing, you are choosing an entry point close to the superior articular process, or this is called a mammillary process, which is a small tubercle on the posterior superior surface of the superior articular facet. If you are choosing that entry point, it will be a little more laterally directed compared to a screw which is placed more laterally. So this is the angulation which we usually keep in mind while placing the screw. And depending on the level, which level screws you are placing, whether it is L1 or L5, it keeps changing. Usually in L1, at L1 level, you have to, angulation is around 5 to 10 degrees, and it keeps increasing up to L5. It may go up to 20 to 25 degrees medially. You will have to direct the pedicle screw. Once you have exposed the bone well, next thing is to get a good fluoroscopy, good AP view. This will help you in identifying the pedicles and entry points. While you are doing the fluoroscopy, the things you have to notice is that this is your pedicle, which is seen as an oval shaped one. You can see it is, the height is more than the width. But what's the problem with this view and this view? Here you can see the superior end plate is seen as two different lines. You have to orient your CM in such a way that you are seeing a single superior end plate. And once that is done, next thing is to orient it in such a way that the spinous process is in the midline. It is equidistant from the pedicles. So once this is done, you can avoid any other parallax error and put the screw properly. So where do you want, what is your entry point? In an AP view, you want to start the pedicle screw at the lateral border of the pedicle, and direct it more medially. So you will choose a point which is almost in the midline of the, in the middle of the pedicle on the lateral aspect. So it can be either on the 3 o'clock or 2 o'clock position on the left side, or it could be a 9 o'clock or 10 o'clock position on the right side. So this is your entry point. So one way of choosing an entry point is that we usually, in the beginning stage, you can put multiple K wires at whatever levels you are going to put the pedicle screw, and do an AP view and cross-check it before you start your actual pedicle screw placement. So this is what I mentioned now. You can see that this is a superior end plate which is seen as a single line. You have placed your K wires, and you can see that this K wire is on the outer or on the lateral border of the pedicle. This is also on the lateral border. This is slightly lower. This is slightly, maybe this is 3 o'clock. This is 9 o'clock, and this is 2 o'clock position. Still acceptable. Here, if you see it's much lower, but we can come in here because you see that the X-ray is not taken in a proper way. The end plates are not seen as a single line. So you need to adjust your fluoro again. Make sure that you are seeing a single end plate, and then decide on the position. Once you understand that, or you accept that this is a good position for starting the, for making the holes, for placing the pedicle screw, what you do next is, as Jacob mentioned, you start with an awl, make a small hole here, and then pass your pedicle probe. What we can do is that when you're passing the pedicle probe, the first 2 centimeters or the 20 millimeters of the pedicle probe will go through the pedicle and then it reaches into the vertebral body. During that time, you are directing the pedicle probe lateral to medial, so that when you pass 20 mm of pedicle probe, the tip of the pedicle probe should reach the medial part of the pedicle. Is that clear? You are passing the pedicle probe from lateral to medial, and when you are passing 20 mm, the tip of the pedicle probe would have reached the medial border. That means you have safely reached the junction of the pedicle with the vertebral body. In case you have passed 1 centimeter and you have seen that it has already reached the medial part of the pedicle, that means you are more medially oriented. You have to reposition. You have to take a path more laterally oriented. Or if you are you have passed 2 centimeters of pedicle probe, but still you haven't reached the medial border of the pedicle, that means you are too laterally directed. So you need to reposition and then pass it again. So the steps are pretty same. Once the pedicle probe is passed, you use a probe to feel the borders of the hole you have made. What we can do is you can pass the blunt probe and feel it all the way from below up. Feel all the walls, especially the medial wall and the inferior wall. Because any breach in the medial wall or inferior wall will cause a neural injury. And once you are sure that you haven't made any breach, you can untap the pedicle with 1 or 2 millimeters smaller size. And once the tapping is done, then you place the screw. So this is a post-op X-ray of intra-op X-ray of a L4-5 pedicle screw place. You can see this is the L4 level. The pedicle screws have been placed. You can see that it hasn't breached across the midline, which means that you are not too much medially oriented. And you look at the sagittal view, you can see that you have passed the screw almost like 2/3 of the to the vertebral body. And this is a post-op CT scan which shows that the pedicle screw is placed within the pedicle without any breach. So what's the size of the pedicle screw you want to use? It depends on the size of the pedicle where you are going to place the screw. As far as possible, you will try to put a larger screw because the strength of the screw depends on the inner diameter, and the pull-out resistance depends on the outer diameter of the screw and also the pitch of the screw. So as far as possible, you will try to place a screw which can be accommodated within the pedicle. So how do you decide that? That you have to decide based on the preoperative CT scan. You have to measure the transverse width of the pedicle before you plan for the screwing. So when you come to placing the sacral screw, the advantage of sacral pedicle is that these are quite large compared to lumbar, and you can easily accommodate a larger screw. And the entry point is more or less same. That this is the L5S1 joint, facet joint, and you stay lateral to the facet joint at the base where the superior articular facet meets the alar. That's the entry point. And the pedicles are so medially oriented that you want to increase the angulation. Previously, we said up to 5 to 25 degrees for the lumbar pedicle screw. Here, you can go up to 30 to 40 degrees medially oriented. And sagittally, you want to get a good purchase because the sacral bone contains more of a cancellous bone. You have to have a longer screw place. For that, you angulate your screw directing towards the sacral promontory. That will give a longer screw placement, and you can try to get a bicortical purchase also. So as long as you are directing it medially and superiorly towards the promontory, you can have a bicortical purchase, and it won't cause any damage to any vascular structure anterior to the sacral promontory. So the next part of the discussion is about the lumbar decompression. And before the lumbar decompression actually means it includes two separate entities. One is the bony decompression and the decompression of the neural structures, removing all the soft tissue, thickened ligament of flavum, or any disc prolapse, which is compressing the nerve root. But before I go to the different types of decompression, we have different types of decompression based on the extent of the bone you are removing. It can be either a laminectomy, it can be a hemilaminectomy, something called coronal hemilaminectomy, which many people are not aware of, partial hemilaminectomy, or a laminotomy. What do you mean by a laminectomy? Laminectomy means you are going to remove the entire lamina, including the spinous process and lamina, keeping in mind that we have to respect the lateral border of the pars interarticularis and leave behind adequate amount of bone, at least 5 millimeter of bone laterally, to prevent any listhesis. So this laminectomy is done on both sides, then you call it laminectomy. And when you remove the lamina on one side, retaining the midline structures, the spinous process, and you restrict yourself to one side, you call it hemilaminectomy. And a partial hemilaminectomy is when you have removed a part of the hemilamina on one side, you are left behind superior part of the lamina or inferior part of the lamina where you want to decompress. Laminotomy is you are removing just an edge of the superior lamina and inferior lamina so as to get an access into the canal. So that's about the bony decompression. About coronal hemilaminectomy. Coronal hemilaminectomy is a bilateral laminectomy, but as you notice here, we have retained the superior half of the spinous process and superior half of the lamina. Your superior extent of bony resection depends on how where you reach the superior attachment of the ligament of flavum, and you detach the attachment to the ligament of flavum, and you start seeing the extradural felt. That's the superior extent of the coronal hemilaminectomy. And laterally, again as mentioned, we have to leave behind adequate amount of bone laterally to prevent the listhesis. So this is the extent, based on the extent of laminectomy, we have classified into full laminectomy, hemilaminectomy, partial hemilaminectomy, and coronal hemilaminectomy. Once you have removed the bone, you have access to the ligament of flavum. For whatever reason you have removed the lamina, and the amount of neural compression by the ligament of flavum, that the ligament of flavum has to be removed based on how much or on which side it is compressing. If it's a canal stenosis with a ligament of flavum hypertrophy on both sides, you have to remove the ligament of flavum on both sides. For that, you have to understand the attachment of the ligament of flavum. The ligament of flavum is attached inferiorly to the superior edge of the inferior lamina, and it goes all the way superiorly and gets attached to the ventral surface of the superior lamina. So, if you want to remove the ligament of flavum completely, you may have to remove some amount of superior edge of the lamina, inferior lamina here where it is getting attached, and go all the way superiorly where the ventral attachment of the ligament of flavum to the superior lamina is removed. Once that is disconnected, the ligament of flavum is free, and you can remove it after removing this attachment on the lateral side. For a patient with a spinal canal stenosis, probably you will have to remove the ligament of flavum almost reaching the pedicles laterally. So one more entity I want to mention here is the lateral recess syndrome, where the recess, which is lateral recess, which is bounded by the pedicle superiorly and the superior articular facet inferiorly. Whenever there is an hypertrophy of the superior articular facet, you can see that this nerve root which is coming laterally is getting compressed. So it's always necessary that you remove the entire extent of the hypertrophied superior articular facet to decompress this nerve root. Usually the nerve compression is maximum superiorly and laterally. That's where you have to start decompressing and come all the way till the nerve root is exiting the foramen. So for adequate lumbar decompression, the root has to be seen leaving the thecal sac, removing all the bony hypertrophied bone which is compressing the root laterally, removing all the ligamentar flavum and seeing it exiting through the neural foramen. So once you see this type of a decompression on both sides, you are sure that there is no more compression of the nerve root on either side. This is a type of extensive decompression, open type of decompression, which gives very good results for patients with a lumbar canal stenosis. But as far as there's more minimally invasive ways of decompressing the thecal sac, which is called a unilateral laminotomy for a bilateral decompression. Here what we are doing is, we know that the canal stenosis is because of the ligamentar flavum hypertrophy on both sides, or it may be due to a hypertrophy of the superior articular facet on both sides. But we are trying to remove the compressing elements from one side, retaining the midline structures, including the spinous process. And if you see, this is the amount of bone that has been removed to decompress the thecal sac on both sides. So, sorry. So this is a operative video of unilateral decompression. You can see that this is the spinous process and the midline structures are retained. We use a hemilaminectomy retractor, which has got a hook on one side and a plate on the lateral side. And you decompress the and you remove, sorry sir, how do you drop it? Yeah. So you can see this is the spinous process, this is the lateral border, this is the medial border, this is the cranial side, and this is the caudal side. And you've used a drill to decompress the bone. How do you make it forward? Yeah, fine, leave it. So if you use a drill, you remove all the bone, and once the bony decompression is done, see, this is you are detaching the ligamentar flavum from the superior border of the inferior lamina, and you're going more superiorly. You're removing the attachment of the ligamentar flavum from the undersurface of the superior lamina. So now you know that the entire ligamentar flavum attachment from inferior lamina to the superior lamina has been removed, and then you start decompressing more laterally. Whatever ligamentar flavum on the lateral side you are removing. And once you have decompressed on one side, you can go under the spinous process to the other side. Over the thecal sac, you go more to the other side, start decompressing all the thickened ligamentar flavum from the other side, till you see all you can see the opposite root. So you make sure that all the ligamentar flavum on the other side is also decompressed. So two things you have to watch here is, you have to do all the bony decompression before you start removing the ligamentar flavum, so that your drill is not hitting the thecal sac. Next thing is, you have to undercut the spinous process so that you get more space to go to the other side. So once that is done, you get adequate space to go to the other side. You can tilt the patient that will improve your view of the opposite route. Yeah, this is a preoperative MRI of the patient who had a thickened ligamental flavum, and this is a post-op axial MRI that shows adequate decompression with a wide canal and root seen. And this is a post-op CT scan which shows the amount of the bone that has been removed to reach the opposite side. And you can see that the facet joints are left intact, midline spinous process left intact. The advantage is that we are not disrupting the ligaments here, the interspinous ligament, the supraspinous ligament, everything is left intact. So it is a minimally invasive method to decompress the thecal sac fully. And in case you feel like the recesses are a little smaller here, you need to remove the recess, make sure that there is no compression of the root at the recess also. Coming to my next topic, it is the sacrectomy. As you can see, there are different pathologies that involve the sacrum. It can be a chordoma or a dense aneurysmal bone cyst, and it can involve different segments of the sacrum. It can be a lesion involving the distal part of the sacrum. It could be a lesion that goes all the way till the S1 segment. So depending on the extent of the lesion, you have to design your sacrectomies. So this is slightly different from our usual laminectomy because the position, many surgeons use prone position, some use jackknife position, and the flap is usually U-shaped based inferiorly to prevent any necrosis of the skin flaps after surgery. And compared to our laminectomy, the more important things here are we have to remove, you have to divide the sacroiliac and sacrotuberous ligament, and you have to dissect the rectum from the anterior surface of the sacrum. So, as I mentioned, depending on the extent of the sacrectomy you have to do, you may have to divide the sacrospinous ligaments and sacrotuberous ligaments, and a blunt dissection of the presacral fascia to protect the rectum from the while we are dissecting. And depending on the extent of the lesion, you can do a partial sacrectomy, or you may even end up doing a total sacrectomy where you will have to do a L5S1 discectomy and disarticulate the sacrum from the iliac joint. So depending on the extent of the lesion, the sacrectomy can be of different types. It can be a total sacrectomy where it is involved the entire sacrum, or it could be a high sacral where it is seen distal to the S1 segment, or it could be a mid-sacral distal to the S2 segment, or low sacral sacrectomy distal to the S3 segment. So depending on the extent of the lesion, you decide your sacrectomy. So what we usually do here is, once you expose this, you do a laminectomy, and you identify the thecal sac, and you identify the roots that can be safely preserved just below the level of the roots coming just above the level of the osteotomy you can preserve. And once that is done, you will have to ligate the thecal sac, make sure that there is no CSF leak, and you continue your dissection more anteriorly, dissect the presacral fascia from the sacrum, and then go more laterally and start osteotomy at the desired level. So depending on the extent of sacrectomy, if the sacrectomy is done distal to the sacroiliac joint, you may not need any additional fixation to support the pelvis. But in case your sacrectomy is much higher and the sacroiliac joint is involved, in that case you may have to do additional fixations involving the you may have to do a lumbopelvic fixation with the iliac screws. So this is a case of where we have to do a high sacrectomy, and we place the pedicle screws at L4, L5, and then we had to place iliac screws. As you can see, that iliac screws, the entry point is 1 or 2 centimeters medial to the posterior superior iliac spine, and it is directed 30 to 45 degree caudally and laterally towards the anterior inferior iliac spine. And these screws can be really long screws, almost like 6.5 to 7 millimeters, and larger screws which can carry the weight of the spine. So the entry point is almost like a 2 centimeters medial to the posterior superior iliac spine and directed towards the anterior inferior iliac spine. And the screw, the post-op scan shows that the screw has been placed within the iliac bone without any breach of the cortex. And this is directed caudally and laterally towards the anterior superior iliac spine. So this type of, there have been different methods mentioned. You can put additional screws, like you can put 2 iliac screws, when you can put one more superiorly, directed more superiorly and laterally, or you can place something called, if you not completely disarticulated the sacroiliac joint, but you need additional support, you can start a sacroiliac screw which you can put either at S2 level or S1 level and going across the sacroiliac joint into the iliac bone. So these are the different methods in which we do a lumbopelvic fixation for a patient with whom we have done a sacrectomy. I think that's the last slide I had.
Any questions for Dr. Bijesh? Thank you, sir, for the topic. Once, sir.
Good morning, nice presentation. So you showed that unilateral laminotomy with bilateral decompression. So in the post-op MRI also there was at the foraminal level there was some ligamentum flavum which was there. So how do you decide clinically, how do you choose the patient for the laminotomy with bilateral decompression? Yes.
It is much easier for you to go to the contralateral side from this side, and you can angulate as much as possible laterally, so you will get an access to or the opposite foramen and the lateral recess on the opposite side. But if you want to, on the same side, if you want to do more of a bony decompression, if you see that more of a lateral recess decompression you have to do, I think that going from the ipsilateral side will be much more easier. But if you remove the ligamentum flavum alone on the opposite side, it will be much easier from the opposite side. I want to remove more bone laterally, I'll choose the same side. If I want to go for more of a ligamentum flavum hypertrophy alone is causing the compression, I go from the opposite side. I found it much more easier for me to remove the ligamentum flavum from the opposite side.
Thank you, sir. Now I request Dr. Vivek to just give a token of appreciation to Dr. Bijesh. Now I request Dr. Edmund to come and tell us about the radiological anatomy of MIS TLIF.
Very good morning. It's indeed a great privilege to stand in front of all my beloved teachers, also seniors, many of juniors, and well-known faces. Thank you for making it to the occasion. Today talk is about radiological anatomy of MIS TLIF. The outline of the talk is going to be on introduction, why we need to do MIS TLIF, and what is the relevant anatomy, what is the radiology that we need to study, what are the intraoperative landmarks, and what are the procedures, and what are the common pitfalls. We all know why majority are preferring for minimal invasive spine surgery is that the studies have proven time and again. There's a minimal tissue trauma and blood loss, minimal post-operative pain, and hospital stay is minimal, that decreases the burden on the patient. Recovery is faster and reduced hospital cost. It is provide a minimal invasive spine surgery, provides adequate decompression, and it also has a very good safe and effective fusion technique. You have to evaluate your own results with the prospective data collection and analysis protocol, and you have to modify your technique and adopt which suits you better. Also, there is tendency to go towards the less opioid with the introduction of ERAs. Some people are preferring to do awake MIS TLIF too. This study has shown the long-term and clinical outcomes of MIS TLIF for a degenerative lumbar disease, and we found that there were no significant differences between open and MIS at a 2-year follow-up. But however, the analysis shows that there is a trend in favor for minimal invasive spine for ODI, visual analog pain score for leg pain, and VAS back pain. MIS TLIF seems to be effective and safe alternative for traditional open TLIF in a long term. What are the different types of MIS TLIFs that has been described and what exists in the literature? One is by using a tubular retractor. The other is going for a paramedian TLIF incision and put percutaneous screws on one side. The other variant is one smaller paramedian incision for TLIF on all other percutaneous screws. And some prefer midline incision for symptomatic side of TLIF on all other percutaneous. And now with introduction of navigation, things are much better. I prefer to go for a midline incision for on the symptomatic side of the TLIF, and all other things would be done percutaneously. What are the indications? Most commonly, it's favored for grade 1 and grade 2 listhesis, fail back and recurrent lumbar disc, and those patients who have degenerative scoliosis. What are the contraindications that we look for? It's usually best to avoid in the initial few years of your practice for severe grade listhesis, as the anatomy can be confusing, and for lumbar spondyloptosis, and whenever you have unfavorable facetal anatomy. My previous speaker had enumerated all the anatomical variables and what are the anatomical standpoints that are in relation to the lumbar anatomy. So in want of time, I would be skipping through this. This also has been covered about attachment of the ligamentum flavum. And also we have studied about the facetal anatomy. I would like to draw all your attention towards this particular point. It's called the Cambin's triangle. Cambin first described this triangle in trying to reach to the disc space. As you can see, this triangle is where all our interbody work begins, and this forms a very important landmark even in open TLIF and minimal invasive TLIF. The triangle is bounded by the disc, and you have the superior articulating process and the pars interarticularis and the nerve root which comes onto the top. This is a very common corridor that has been used by pain procedures and also for TLIF and for expanded transforaminal corridor. Again, to stress on the points that are of importance, this is the body, the pedicle, the transverse process, superior articulating process, the spinous process, the pars interarticularis, and the inferior articulating process. And knowing your anatomy, radiological anatomy, and getting this view is very important. The same things on an AP, the transverse process, the pedicle, the lamina, the spinous process, and superior and inferior articulating process. This was a study that was published way back in 1987, which describes about facetal joint hypertrophy. Why is this very important? Because the facet joints form the key in your minimal invasive spine surgery. On a preoperative X-ray and preoperative CT, if you see that the facet joints are not favorable like this, where there is a gross hypertrophy, destruction of the facetal joint, and with gross overriding, it may be difficult to dodge or dock your tubular retractor. So identifying the facets and having a favorable facetal anatomy is very important in order to perform this surgery. This is the theater setup that we have at the place where I'm working currently, and positioning and using all the important gadgets that are available will provide a safe surgery. The importance is about positioning. You have to always make sure that you protect all the pressure points by using adequate padding. The spine frame, the Allen's frame helps for removing, it helps in easy positioning too, and also useful for obese patients where we have abdominal compression. It removes all the abdominal compression and makes the spine surgery much comfortable. This is a patient that has been positioned. We can see that arms are padded, the abdomen is free of compression, the knees and everything is protected unless it is having a cross check. It's important to see the eyes are padded too. And once you are positioned, it's important that you get an X-ray and get a very good end-on view. And also it's very important to make sure the disc space are parallel. Getting the correct view is important. And we have to stress on getting the correct view so that you see your pedicles, you see your superior end plate and inferior end plate, and you see the lamina. Moving on to the steps that involve in doing the MIS TLIF. As compared to the open TLIF, the first step would be to do the interbody work. So in the next few slides, we will be going through what are the steps that are involved in doing this interbody work. As you can see, the work involves predominantly in the Camden's triangle. So as soon as you have exposed the facet joint and the parts and the lamina, you do drill and take out the inferior articulating process on the concerned disc space. Then you do a part of dissection over to the superior articulating SAP. You see the traversing route, and this is the exiting route. Once you have identified this, then you will be able to perform the surgery. So this is an example of using the surgery being done using a tubular retractor. As you can see, the facet forms the key. So by using a serial dilatus, you come to the desired facet joint, and you have the expandable retractors with even the light source that helps you to see this picture. So all the dissection is going to be performed in this manner. And once you have identified that, the steps are fairly simple. You do the discectomy, and you do the shavers, use your disc preparation, and you insert the cage. So I will briefly run through the operative steps. Where is this? Yeah. Yes. So this is a patient who had presented with back pain. She had an L5S1 listhesis and pars fracture. We can see this is through a midline approach, which Dr. Vijesh had discussed in detail. This is the inferior articulating process, and the lamina is drilled. Then we are positioning the chisel to do the removal of the inferior articulating process. So using a chisel helps us to save a lot of bone. And it's a fairly simple process. And use the bony rongers to preserve all the bone, which we use it subsequently for the interbody work. The ligamentum flavum being removed. This is cranial, this is inferior, this is medial and lateral. This is the SAP, the thecal sac in view. And as described previously, we use the same approach to decompress even up to the opposite side. That's a thecal sac in view. And we are coming towards the Camden's triangle, removing the ligamentum flavum. You can see the traversing route clearly seen. and taking part of SAP to facilitate interbody work. The disk space identified. This is the exiting route. It's not required to see in all cases. Then removing the disk. The shavers using to remove the disk, residual disk. Adequate disk preparation is of key. Checking the disk height using the cage dilators. So some part of the disk was left behind. This is the bone graft that we secured in that process, and we are packing the base with the bone graft. We are still preparing some part of SAP to facilitate the cage insertion. This is the peak cage, or you can use titanium cage filled with the bone graft. The cage is being deployed, and check its position on an AP. This maneuver helps for oblique lie of the cage. And this is the end result. So once the cage is deployed, next step would be to just close that incision with a small stitch. You don't need to close the wound yet. Then we go for the MIS screw placement. So it's very important that we have described in the previous talk how important it is to identify the correct identification of the pedicle and the entry point. As you can see, the different pictures from A to D depicts the length of the pedicle screw and how the screw is being deployed. The ideal way is to, this defines everything. So once you identify the pedicle of interest, you start at the 3 o'clock border, whichever way. This would be 9 and that would be 3. And our focus is to reach to the medial border of the pedicle. And what are the steps that we need to see? So you place a K wire, and then you start inserting the K wire gently using the Jamshedi needle, and then you try to reach to the medial border of the pedicle. So in a lateral view, so when you are starting, you would be here, and when you are in the middle, you will be in the middle of the pedicle, and once you reach here, you have reached to the medial border of the pedicle. So it is very important to take AP and lateral shot to confirm your position of the Jamshedi needle. And once that's done, you need to put your K wire and put in serial dilators, and the MIS screw has to be placed. So here I run a small video which shows the position, what is the steps that are involved. So here we are getting an AP view, seeing that the trajectory is in good. It's always good to have 2 people doing it at the same time so that we can minimize the radiation exposure. Now that can be avoided using the navigated drills too. Place your incision. Then put in your Jamshedi needle and check the position. And once you are satisfactory with the placement, with a gentle tap, going till you are up to the middle of the thing. Similarly, you repeat to the opposite side. It's always important to place your incision on the transverse process so that we are lateral to the pedicle. Then take your AP shot and we have confirmed that it is good. Then insert your K wire. And once it's confirmed, make sure you stabilize. We use the tap. An important thing is always you can see one hand is stabilizing the K wire so that the K wire does not get dragged inside. So once the tap is done, next is the screw placement. You have to remove the first and second dilator. the screw will purchase the path that you have created. So there is no necessity for you to keep on doing. The same procedure is repeated on the opposite side. See, the attention is paid on the KY so that it doesn't migrate. Using a ratcheting handle, you can easily deploy all the screws. Once the screws are placed, you have to make sure the insertion of the rod. The rod gets inserted through the pillars of the screws, so there is no necessity to make a separate incision. It depends on the set which you are using. So you have to confirm that the rod is on either side of the screw heads, and once you have confirmed it, you place your unis. And then you place the cylinders to protect the screws, and then you do the final tightening maneuver. See how the screws are in line. You have to mark your incisions well. This step shows how to break these pillars. And it is fairly simple to take it out. So it's always important to mark your incisions in a serial way so that they are all in line, so that you don't have difficulty in placing the rods. Sometimes if you are not paying attention, you can have one incision here, one incision there, then you will have difficulty in inserting your rod. These are the few examples that we have done there in that setting. This was done in way back here, and you can see in L45 grade 1 listhesis, getting a correct view, interbody work being done, then cutaneous screws being placed, then rods deployed and fusion attained, and in proper 3D CT angio had shown the screws are in place. And we have the post-op X-ray at 2 years. You can see the size of incision. There's a small midline incision, and these are the incisions used. You can usually prefer, if you want to use a transverse incision, you can use transverse. If you want a longitudinal, you can use a longitudinal tube. Similarly, one more patient, and you can see that we have gone through a unilateral midline laminotomy and adequate decompression. This is a pre-op, this is a post-op, there's a good decompression, very minimal muscle injury. Patient has done well. You can do single level and 2-level T-lift too. It all depends upon how comfortable you are. It can be done through the same procedure. This is a post-op X-ray at 2 years showing a good bony fusion. The case that was discussed, this is the pre-op MRI showing a grade 1 listhesis and pars fracture bilaterally. And this is the post-op at 6 months. We saw that there is a good bony fusion. So it's important that you prefer the procedure that suits you. I personally prefer using a midline approach because this can obviate the need for taking repeated X-rays to get your docking onto the facets, and also even unfavorable facets can be dealt by using a midline approach. And then once you're familiar doing a unilateral approach to the contralateral side, this becomes easy. And it always doesn't require to have a high setup. It can be done in a basic setup too. Learn your 3D anat and practice. It's very important that first surgery might take 6 hours, 7 hours. That doesn't mean you give up. It's important to repeatedly do the same procedure, and with consistency and over a period of time, you'll be able to get good results. Thank you again.
Any questions for Dr. Edmund? Thank you, Edmund. Now I request Dr. Vivek to give a small token of appreciation to Dr. Edmund. Thank you, Edmund. Now I request Dr. Rajshekhar to please come and tell us about uninstrumented central corpectomy.
Good morning. This is just going to be a very brief talk because I don't think you want to hear things where there is no titanium involved. So the first thing that happens when I make these presentations to most young people is that they are shocked. They are shocked that you can put a bone graft after removing parts of the cervical vertebral bodies and retain it in place without using plates and screws and cages and 360 fusion and what have you. So I just want to let you know that you can do it. And we have been doing it for 30 years. Okay, so there is, of course, a technique involved, and this gives you an idea of the type of preparation that you need to make in the body above and the body below, and shaping of the iliac graft, because the iliac graft that you will get, typically we use an iliac graft for 1 and 2 level corpectomies and a fibular graft for 3 level, but the iliac graft is a tricortical graft. So you have cortex here, a cortex here and a cortex here, but this part is cancellous bone. So you need to turn it around in this fashion so that you will have cortical bone on the ventral and the dorsal aspects. Otherwise, if you try to put it in the other way around with the cancellous bone here, it will not be retained in what you call as the mortise. This is a mortise above and this is a mortise below. But if you do this carefully, and believe me, you can do it, you can learn this technique after you, of course, observe somebody doing it. Within the first 7-8 cases, you will get it. And here is our own learning curve over 400 cases. The first 100 cases, we had 6 extrusions. All of them occurred in the first 50 cases. So as we went along, the number of extrusions were just 1 in 100 afterwards, and most of those were due to the fracture of an osteoporotic graft. And this is what the post-op imaging looks like. The graft fuses beautifully. This is an iliac bone graft, and this is a fibular graft after 3-level corpectomy. And there you see the type of decompression that you can achieve with this technique, both in the sagittal images and in the axial images on an MRI. And this is a paper we published on 3-level corpectomy in 33 patients. So we have used this not only for degenerative cervical myelopathy, which is the commonest sort of indication for uninstrumented corpectomy, in over 400 patients, and this is our improvement rates in patients who are in Neuric grades 4 and 5, 4 being those who are who need assistance to walk, and 5 being bedridden patients. And this is a long-term follow-up, with follow-up ranging from 1 year to 19 years, with an average of about 5 years. We achieved an improvement rate of about 3/4 or 72.3%, and the Neuric grade, of course, had changed significantly from the pre-op to the follow-up. But I just want to share with you the fact that this technique, once you're comfortable with it, can be used for other pathologies like cervical spine tuberculosis. You can just manage with uninstrumented corpectomy, no metal at all. You can also use it in an occasional case for chronic traumatic and even actually acute trauma, but you may require metal from behind. But from front, you can use the uninstrumented corpectomy. And these are examples of that. This is a degenerative myelopathy, 3-level corpectomy, again showing you the decompression. But this is the patient with spondyloptosis who came to us, I think, a year or more after the injury, and we did this corpectomy, it was difficult because you have to remove this bone and that bone behind, and you have to make a mortise quite deep down. This is 2, 3, 4, 5, 6, 7, 1, 2. So you have to reach T2. But we didn't do a sternotomy or any such thing, manubrium. We just went in from the neck, through the neck, a low incision. But we did put this patient into a halo. So we put the patient into a halo, and a year later, this is the kind of result we obtained. Here is a patient recently we managed with tuberculosis, and similarly you can see a good bony fusion, no metal at all, and the patient has done well. So I just want to end with this slide. I'll just show you a short video after this. So you may ask me, with all this metal so freely available, why should I do this? Why should I even bother to learn this technique? And the most compelling reason, besides cost of course, is the fact that you're not leaving metal, which is after all a foreign body, in a patient, and the complications that go with metal. Believe me, I've seen several patients with these esophageal fistulas, and it's miserable for them. It's very difficult to deal with those patients who have a pharyngeal or an esophageal fistula with everything they eat coming out through their neck. And several, at least 6 or 7 such patients I have seen, operated elsewhere, come here, and it's very difficult. Along with our general surgeons, we had to manage those cases. So I'll just go on to the video. Can I just have the video, please? It's in the same folder, so you will be able to get that. So this is a very short video. It's a composite video. It's not one patient. It's actually a couple of patients put together. I think one of these cases was operated by Dr. Vivek here, and one by me. So most of the surgery, initial part of the surgery, is just done with the regular rongers. I'm sorry for the quality of the video. It's an old one, and put in the microscope and the drills, you start using the drills only when you come to the dorsal part of the body. A thin layer is left behind, and then I start off with a cutting burr most of the time, and I think that's Vivek doing this. I don't know if Vivek remembers this, some years ago. And that's of course a diamond burr. I reserve the diamond burr for really the last part, and then what we are doing is we are lifting up the posterior longitudinal ligament at the level of the disc and cutting it on a hook, a blunt hook or a sharp hook, and taking off the posterior longitudinal ligament. This is best done at the level of the disc, either the upper or the lower, whichever one is easily seen. And you then want to see the dural tube. You want to find your plane, because what you're going to do is you're going to remove the whole posterior longitudinal ligament till you see the dura. So you start seeing the dura there. You have a glimpse of there you get a glimpse of the dura, and you use fine punches to actually cut off the whole ligamentum flavum, and the last bits of the ligamentum flavum are being removed, and there you have the dura. You see the pulsations of the cord nicely. Put a gel foam there, and sorry, I'm sorry. Yeah, the posterior longitudinal ligament. Yeah, PLL, sorry. Thank you, Vivek, for that. And this is from the other video, where again showing you that the dura is totally exposed, gel foam placed, and this is, if I can pause this actually. Yeah. So this is the tricortical iliac graft that I was talking about. So you see that these are the ledges that I have made in, and this is the cortex. You have cortex here, cortex here. So what we have done is we have turned it around so that the cancellous bone is here, and there is a cortex on the other side. So this will go superiorly and this will go inferiorly, and we have made corresponding mortises into the body's caudal and the cranial bodies. So this is just showing you the graft, because the corpectomy technique is quite standard, I guess, whether you use instrumentation or not. And that's just to show you that this is the tricortical bone graft, and so this is every patient is on traction. Yeah, that's the other side of this is the other cortex that I was talking about. So there are the 3 cortices. The patient is on Garnawell stongs with about a kilo or 2 weight put, and when you put this in, the last part, you will ask somebody to pull on that and put it in. So what I'm trying to do is to try to dislodge that graft, and you can see that it just won't move. And then you release the tongs, take off the weight when you finally get it in. You may have to put a little piece of bone at the upper end if there is a little bit of a gap, that you get some bone. But you see, the whole patient is moving, but the graft is not going to come out. And once you ascertain that, I can assure you it will not come out. You just need to put the patient on a collar. We used to keep them for 3-4 months, but I think even a month or 2 months, you leave him on a hard cervical collar, the Philadelphia collar, and you're done with it. So before I end, I just want to share with you, you can just have the lights on. I just want to share with you, just give me a minute, Vivek, share with you an experience I just had as I was before coming here. I did a teleconsultation today for a 69-year-old male from Calcutta who was operated by a very prominent, very senior spinal neurosurgeon. This patient went to him 5 years ago with just back pain, nothing else, which he's had for 10 years. And he also had a right anterior thigh pain, burning pain. On the MRI, a small intradural tumor, 7 millimeters in size, was picked up at the L1 level. But the surgeon not only did a laminectomy, L1 laminectomy, and took out that tumor, but went ahead and did an L3 to L5 pedicle screw, rod fixation, L4-5 discectomy. And what do you think happened to the patient? He's just as he was before surgery. No improvement, no change in his condition. And that's why he's consulting me now. So that's a cautionary tale for all of you. Just because you have the hammer, don't go around looking for nails. Please don't. Treat the patient. Please don't treat MRIs. I would have managed this patient, 65-year-old with a 7 millimeter intradural tumor, that turned out to be a schwannoma, of course. I would have told him, I think you can follow up. I don't think this is the cause of your back pain. I'll follow you up. You are 65 years old. I don't know the natural history of this tumor. It may grow, may not grow. I can easily take it out when it causes problems. And I would not have done, definitely, an L3 to L5 pedicle screw with rods on both sides and an L4-5 discectomy. Why was it done? I don't know. I haven't seen the MRI, by the way, the pre-op MRI. But I just want to tell you that overdoing this kind of surgery is not only harming patients, but also harming our reputation. Because that patient is asking me, so then doctor, why did this very senior surgeon do this? And this person has gone to Bangalore, Bombay, Calcutta, looking for a solution for the last 9 years. He probably has got meralgia paresthetica on the right side, anterior side of thigh, burning pain, common in elderly patients. Thank you for your attention.
Thank you, sir, for those insights. I really appreciate the knowledge and the know-how which we have got from you all these years. We have used the central corpectomy principles taught by you to manage a case with a C2 vertebral body lesion. So we had...
Actually, yeah, even for tumors we have used.
Yes. So thank you for all that. I'll request... One sec, sir had a question.
Sir, that's very nice. I've seen this presentation many times from you. How do you keep the mortise in the body? How do you
make the mortise?
Do you create another dent in the body for it to fit correctly?
Yeah, absolutely. Okay. So you can angulate your drill. I typically took, I think, a 4 millimeter drill, and you just angulate it.
Okay.
And you know, the drill bit gives you an idea of the depth because it's 4 millimeters. So you go till you stop seeing the nub, you know, the bit itself. Okay. And you just do that. Similarly, you go down and do that.
The traction helps to put
and then slip in the upper part of the graft into the mortise you made above, and your graft size should be such that it's a little longer than what you measured as the defect. and you will find that your lower part of the graft is sitting on the lower body, the superior end of the lower body. It's by 2 to 3 millimeters or 4 millimeters. Then once you pull, it just
Slips in.
just starts getting, stuck into that. Maybe still not yet. And then you take one mallet and some impactor and just tap it in gently, and then you'll suddenly find that it has gone into the mortise. And then ask them to release the traction that they're giving, the additional traction. So there is manual traction in addition to the weight that's already there. And then you ask them to release that, and you'll find that it's just gone in, and it just stays in place. Vivek has done several of that. Bijesh, if he's around, he's done several of these uninstrumented corpectomies. No, I just want to say that it's not, I'm not the only guy who can do it. Anybody can do it. All these guys have done it, and they're very comfortable with it. Thank you.
Thank you, sir. Dr. Vivek, we'll just felicitate Dr. Rajshekhar. Thank you very much, sir. Thank you very much, sir. May I now request Dr. Karunakaran to come and tell us about spine endoscopy.
Very good morning to all of you. At the outset, I must thank Dr. Vivek and his team for giving this platform to me, and thank Professor Rajshekhar for this eye-opener. This lays the platform for me to talk better to go more biologic, and the most important point is his conclusion remarks on good clinical evaluation doesn't replace any technology, so that's very important. So we have to be very selective when we're putting a knife. It's just not because we got something new, something which can be used for everywhere. It is very tempting to use in most of whenever you see a disc. But is it symptomatic? Is it going to give a good quality life when you do a procedure? Is something which you have to keep it as a bottom line. So with this in mind, I would like to start my presentation. Like we all know that the disc can be central, paracentral, foraminal, extraforaminal, extruded, migrated, whatever may be the situation. Sorry, I will do that. Yeah, whatever may be the situation, the endoscope can be used effectively to address these sort of compressive pathologies extradural. This is the central part. What we do is we use the interlaminar approach for which is extraforaminal or the foraminal. We use the transforaminal approach for using the endoscope. Based on the location of the disc fragments, we still plan the trajectories. All of these are minimally invasive approach, right from microdiscectomy, tubular discectomy. What I prefer to do is the sutureless percutaneous endoscopic discectomy. Why do I do it? I want to do it little better than what it can be done by the rest. Aiming at giving a better quality of life. The bottom line is better quality life. See, all these are minimally invasive, but the damage is going to be whatever muscles are there is still damaged. The bony structures, the ligamentous structures are all compromised. And having a very small skin incision doesn't really matter. So whatever we say is disc surgeries, wow, it's a terribly simple surgery. At end of the day, sometimes it land up simply terrible. So whenever we sit in the patients, we just anxiously keep waiting. What is this patient going to tell? Could we hide from him? Better he doesn't say any symptoms. Is he going to crib about what are the surgeries? And so all these things made me think about something more biological, more comfortable, get the report, feedback on the table. So I started with doing a transforaminal approach. This is what we need to understand. What is this transforaminal approach? The conventional approach is doing the interlaminar approach. Here you have to use an extraforaminal approach. Here you have to understand that we are coming from far lateral approach away from the midline, approximately 12 to 15 centimeters from the midline. And here we have to understand that we are going between the two pedicles, and along the inferior pedicle we have the nerve root, and on the end plate on the lower side, and the ligamentum flavum and the disc anteriorly. So that triangle is what we are going to utilize. And based on the levels, like if let us say it's going to be higher level, we have to plan the trajectory based on the visceral structures. Like on your right, you have the renal structures which might come on our way. So we have to plan our trajectories based on the access, available access based on the structures. Like lower level, sometimes the L5S1, the iliac crest may be the higher level. So we have to look at the MRI as well as the X-ray. So people keep asking after doing an MRI, why do you want an X-ray? Both for orientation during intra-op and during pre-operative planning, we use the X-rays. And based on the pathology, whether the fragment is predominantly within the canal or pathologies like in the central part, like the discitis, we use the angles. We have to go steep, or whether we have to be very shallow in the access. And the instruments is a blessing in getting these things accomplished, because what you can see is the initial version of the 2.7, which were all flimsy instruments. Then they came with bigger diameter working channels, so that the more robust instruments can be used to handle more tough tissues. And now what we use is the 4.1 mm working channel, and it has got an outflow, that is for whatever we use. This endoscope is under continuous saline irrigation, so we need to have the saline coming out whenever we are putting the saline in. So the design of the scope itself is not circular, it is an oval type of an endoscope. So whatever saline which comes through the irrigation channel will go out without causing any much of pressure. And the illumination is very good, fiber optic, and we use a 4K camera system. The instruments, as I said, has to be sturdy, and the spring at the back, even if it breaks, it snaps off only at the spring part. You don't have to be worried about the instruments breaking and leaving it back there. And you, like a pen field, the jaw of the cutting ones can be used. The disc punch, if you need a straight punch or an angulated punch, can be used. Whichever the armamentarium must be good, but if you compromise on your armamentarium, you might land up doing an incomplete job. So it's all following the steps, and you have to go step by step. For a lateral approach, you need to have only just two markings. You have to identify the facet anteriormost border. That will be the maximum extent. You cannot go further down, more lateral on that. And if you want to go more steeper, you have to identify the spinous process. You need to just have these two lines. And in the AP, you have to just mark the level which you want to go. Once the key of this, the key to the success of this procedure is you need to place the needles exactly and the disc fragment. Most of the time, it's a paracentral disc. In paracentral disc, you need to have the needle position medial to the pedicle in the anterior posterior view, and in the lateral it has just touched the posterior cortical line on the lateral view. And this, if you have got this position right, the needle placed, then everything is straightforward. You have to have the guide wire on it, and then the dilator passes. The dilator will pave the way for the working cannula, and once the working cannula is inside, then the scope goes in. And here what we are using is a far lateral approach, where it is almost 15-20 centimeters from the midline, and the endoscope visualization is very good because of the optics as well as the continuous saline irrigation. The procedure is done in two ways, both under under local anesthesia and general anesthesia. We initially started doing most of the procedures under local anesthesia with conscious sedation, but now we switched to general anesthesia, and we take up local anesthetic patients only. They are high risk patients for under local anesthesia. And preoperative, this is a case example with the preoperative SLR of around 30 degrees, very positive. And we always look at the X-ray, and the X-rays, why we look at it is we want to know whether we get an access for an L4, L5, does the iliac crest come on the view, and also compare which is the safest access. If you have a very good interlaminar window, and if you can get an access through that, we would prefer that. But most of the time, if it is the transforaminal is the preferred approach, because we don't have to do any type of tissue cutting there, and we have to just dilate the tissues. And here, what we did was a transforaminal approach. The large paracentral disc fragment was confirmed on the MRI, clinically matching with this MRI findings. and we use the dilator. You can see that the tip of the working sleeve is on the medial border of the pedicle, and the instruments grabbing the disc fragments, approximately 2 centimeter size disc fragment comes out. On the table, we after the procedure, we flip them and check this SLR. It goes back to 90 degrees. And the bonus to this is we barely see any scar on his back except for his whatever is burnt out skin after long course of hot packs and ice packs. And you cannot barely see any scar. I zoom it, still you cannot see the scar. And in high risk situations, what we do is we put the patient under conscious sedation. We not only have the advantage of seeing things, we also get the feedback from the patient whether he's got the relief of pain on table, and that's the plus. When you have multiple discs, you are trying to find out on nerve root blocks. You localize it, and then you take him up to the patient on the table, and if you check on table whether after removing the disc. I also ask them to do a straight leg raising by dropping the legs down, asking them to do a McKenzie extension to see if they have got relief of pain. And after visually confirming and also getting the inputs, we conclude that the mission is accomplished. In cases where we are not able to do an transfemoral approach, what we use is an interlaminar approach. I'll show you in a case example where we got a massive disc prolapse at L4, L5, which has inferiorly migrated. If you have to do a transfemoral, you can still do a transfemoral by using, you have to compromise on the pedicle stability, where you have to burr the pedicle or you have to go transpedicular. All these things is possible, but I chose to do an interlaminar approach where the interlaminar window was adequate. You can see that almost you can have a beautiful clear operating field, like there is no blood in the operating areas. That's because we have tools like radiofrequency ablation where we can have a good control of the the bleeders, as well as it is under continuous saline irrigation. And the large disc fragment comes out, and the next day when we change the dressing, you can barely see any wound there, and it's most of the time don't use any sutures. It becomes very handy, particularly in revision surgeries. This was done again minimal invasive through using a tubular retractor system or the Destendo system, where the laminectomy was done. He had a recurrence on the right side, radiating pain. What we did was just a transfemoral approach. You could remove the fragment in toto, had a good pain relief, and you can see that the previous scar was still small, but there is extensive tissue damage, but we could remove. Imagine this case, if it comes for remission, you would have, most of us would have planned for a stabilization procedure, because the scar tissue has to be excised. The more we release the scar tissue, we go more lateral, the more stability gets compromised, and we might think of doing these sort of stabilization procedures. Or even the blood loss is going to be significant with these scar tissues there, and bleeding is going to be held. What we usually think is, in case of the patients with neurological deficit, should we use endoscopy? This gentleman presented us with a 60-year-old gentleman presented with back pain on the previous day night. By the time I could come and see him on the next day morning, he started developing weakness. The weakness was progressive. When he was surprised that he couldn't lift his left lower limb, and he had a quadriceps muscle weakness. Yeah, so we don't have to change our plan because there is a significant muscle weakness. What I usually do is, in elderly, I just also do a CT scan to know that if they're severely degenerated, it can be have a calcified portion or sometimes osteophytes. You can see that there is a large osteophyte as well. And the same technique, transfemoral approach, I reached the middle border of the pedicle, kept my needle and the guide wire in the posterior cortical line, removed the disc fragment. After a 6 weeks period, you can see that he has shown significant improvement in this neurology, and this is his post-op neurology. So neurological deficits doesn't stop us. We use it even for cauda equina. In emergency, we do endoscopic decompression in cauda equina syndrome. So if you are not able to get a transfemoral approach, use the interlaminar approach. The beauty is it is like a joystick. You can move your endoscope in different corners of within the canal and search for the fragments. And I'll tell you shortly that the endoscope design also helps us in looking at different corners of the canal. So we have to just make a rent in the ligamentum flavum, get the access. The positioning is you try to open up the interlaminar window, particularly for L4, L5 by wedging it. And first step is just have to mark the widest point of the interlaminar window, make a small stab incision, And over this tab incision, you introduce the dilator, and dilator followed by the working cannula. While introducing the dilator, you have to be a little careful, because I've seen that during the learning curve, you sometimes inadvertently plunge into the canal. When you suddenly start seeing, you are seeing the neural structures, you should be careful. So some of the tips I would say is make a fascial incision a little bit longer, and try to land on the lateral border of the facet joint, and then walk into the ligamentum flaum. And you can also feel for the bouncing back of the ligamentum flaum if you have adequate release of the dorsal lumbar fascia. So once you do that, the tubular part is you can use it very effectively for both dissecting the tissues, moving the tissues around. You can also hold the bleeders away from the working field. And the bevel has to be opened up medially, so that you can see the ligamentum flavum once you use the dilator. Once the dilator is in, you clear the tissues in the operating field, the muscles and the fascia and the small amount of fat over there. And the off axis of the endoscope will help you to visualize the different corners. What I mean by off axis is we use a 25-degree scope. So if when you rotate it, you can see the different corners of the canal or superiorly, inferiorly, so that you can have a complete clearance. And also you can see underneath the neural structures whether if there are any extruded, migrated or missed fragments can be effectively searched. So it can be used for different situations other than the disc, like lateral recess, osteophyte decompression, if you have a high-speed burr or upcutters. Subarticular, paracentral, central disc herniations and synovial cysts can be utilized. And you need to use it, apply the techniques for using these instruments. Like if you see on the left, the sheath is there, which will displace the instruments more away from the target. So if you move the sheath above, you can see you are getting close to the target. So some of these tips will help you to go close to the fragment, because this is a very small instrument. By rotating the scope, still you can see that when you are far away, when you rotate the scope, the working cannula comes close to the target. So some of these techniques can be used during the interlaminar approach. The micro punch is an angle 90-degree for the use for ligamentum flavum. The open jaw of the micro punch can be used as a Penfield dissector, as I said, the jaw. And when you cut the ligamentum flavum, you go step by step, you can start seeing the color change from yellow to a darker color. And the irrigation fluid itself will displace the thecal sac, so you don't have to be worried about the catching of the thecal sac. And blunt dissector can be used for releasing the adhesions. So the clear visualization and these tools help to prevent these sort of neural injuries. Should inspect to know whether it is completely decompressed, you have to inspect the medial border to the tip of the superior articular facet and make sure that it is adequately decompressed. Other than the disc, we also use it for canal stenosis and grade 1 listhesis for decompression. This is again another case example where had an extruded disc. Here why we chose to, here this is interesting because how we the decision making is interesting here. So the L4, L5 large extruded fragment was seen, almost getting to the tip of the L5S1. So what you can see in the X-ray is the interlaminar window of L4, L5 was very small. So I thought I would go at L5S1 and try to pick up that fragment and come as a whole fragment. But what happened was I couldn't. So the reason why I didn't use the L4, L5 interlaminar window was you need to have special tools like high-speed burr. Why should I compromise? I should make a tissue preserving approach. Then what I ultimately did was I still preserve the tissue, but I had to make two small incisions there. The extruded fragment was removed because it was a large extruded one to the L5S1. You could see that my probe could reach up to the inferior border of the pedicle, so that part of the fragments can come out, but still there was L4, L5 through the parent disc which was there left behind. I couldn't reach there, so I had to use the small interlaminar window which was there. Without cutting on the bony structures, the ligament, I could reach there, remove that fragment. So end of it, there was two small incisions, and he could get back his normal level of movements, and that was the two fragments. One from the above one is L4, L5, and then this one is the L5S1. And that's all. I have a presentation on cervical endoscopy as well. Shall I continue, or we will wind up? Because there is no, we are not going to demonstrate cervical endoscopy, so better I will wind up here. Okay, thanks.
We can take some questions now.
Yeah, any questions for sir? I had one question, sir. Is there any patient selection which you carry out in terms of history or radiological assessment? Do you only take out the extruded fragment?
Yeah, of course, the clinical symptoms will dictate our surgical plan. For once we see that they have not responded to a long course of 6 weeks of conservative treatment, or within the short period the work demands or the pain is excruciating, we plan for the procedure, which would neurologically, clinical, radiological correlation was there, we intervene. So that's the plan, and anything which is extradural compressing on the cord, we are able to access and remove the fragments. Like we don't say that we are going to do open procedure, so all endoscopy only.
Hi, Karan, that's very nice demonstration. How do you deal with similar patients who have severe ligamentous hypertrophy, severe lateral recystinosis, same side and opposite side? Can you also go to the opposite side?
Yeah.
How do you manage those?
Yeah. Thanks for the question, Dr. Murli. We still use the endoscope, but the endoscope is a bigger one. The size of the working channel is 5.5. Start on if there are going to say the symptom is on both sides, we ask which side is more severe. If they say both are same, then we choose. If they say the right is severe, then we start working on the more symptomatic side. What we do is you have the descending facet, start burring on the descending facet, then we start seeing the ascending facet. We remove the ascending facet as well, detach the ligamentum flavum. The superiorly and inferiorly again same use the burr, detach all the ligamentum flavum. Just walk along the inferior lamina, across the opposite side, burr and detach the ligamentum flavum. Just walk close to the bony ligamentous and osseous attachment. You just detach it and go as far as possible up to the ascending facet. Then again come from above, come along the descending facet. Detach the ligamentum flavum with the dissector. The ligamentum flavum and the bony part can be burred and separated off. So the ligamentum component and the bony component is taken care of. And the dural visualization, we see up to, as I said, from the superior articular facet to the pedicle, the same side and the opposite side are visualized, because the scope is a mobile structure, so we can shift and see the opposite side as well.
Similar to the open way within newer instruments, we can do all these things now.
Yeah.
Burrs and other things.
The burrs is very useful, and particularly the diamond burr, the chances of neural injury is very well taken care of.
Thank you for that talk, sir. My question is regarding CSF leaks. I know the irrigation fluid pushes the dura away, and what is the incidence of CSF leak in endoscopy in your practice, and how do we repair it in case there's one?
This CSF leak did not come in my earlier days of my practice, so I was very careful. And as my hands become free, I become a little bit more careless. I think out of my 700 plus cases, I had only one, that is on a revision case. So what we did was, you can see usually when there is a dural injury, there is a small rootlet coming out. So immediately we have to stop that irrigation, so we don't want that fluid to get inside. So we stop, then we use the gel foam, try to maneuver with the scope without the saline to try to put the rootlet inside, but I failed. But what I did was just put a gel foam there and left it. We did a check MRIs to see if there is any CSF coming out or we have to go intervene, and based on the symptoms we decided to leave it there. But since the check MRI did not show any free fluid in the space, we just left it at that. But the patient had hematomylia, the patient had some pain, so we just waited for some time and settled. The disc is again, it's amount which is compressing on the spinal canal. Whatever spinal neural decompression is the aim, so we do a neural decompression. We put an endoscope and gently try to fish for any loose fragments, like what we do in another open procedure. Nothing comes, I leave it.
So we are not actively incising the annulus and removing the disc from the...
I usually look for the weakest spot of the annulus. Like when I probe, it immediately gives way, or sometimes you can see a very clear rent there. So through that I go. I don't have to create any extra rent over that. So through that I go, explore for the free fragment. More predominantly I look at the canal. Like canal has to be free, and disc coming out is unpredictable. So I will be less aggressive on that.
Thank you, sir. Thank you for your lecture. Now request Dr. Vivek to give a small token of appreciation to Dr. Karunagaram. So thank you everyone. This brings us to the end of our lecture session. We have overshot of time by 15 minutes. That's a good achievement. Now we'll all move towards anatomy hall, where we will have a lunch first and then a cadaveric workshop. Thank you.